Hi, and welcome to Bike Talk, our informational video on patellar tendinopathy in cyclists. I'm Nate Reddington.
And I'm Matt Weber, and we will be your guide to addressing patellar tendinopathy in the cycling community. Because of the high-load, repetitive nature of cycling, it's very common to see cyclists with neck or low back pain, wrist and elbow pain, knee pain, and even ankle pain.
Yeah, I think I have all of those pains.
Okay. Specifically at the knee, some common pathologies you might see in clinic are patellar tendinopathy, quadriceps tendinopathy, or IT band friction syndrome.
With the increased rise in popularity of the Tour de France and mountain biking as a sport, it's becoming increasingly more important for clinicians to understand some basics of properly fitting a bike and how errors in training can lead to stress injuries. In this video, we're going to dive deeper into what patellar tendinopathy is and how it can be brought on by cycling. Anterior knee pain is one of the more common complaints that cyclists will have, and as a result, one of the more common diagnoses you'll see is patellar tendinopathy. The patient will likely complain of increased pain during lower or harder gears, and off the bike, they may complain of aggravated symptoms during walking or stair climbing. Tendinopathy is an overuse injury that can be caused by increased strain and pull of the quadriceps muscle over time. During a 1-hour session of cycling, a person can average up to 5,000 revolutions. You can see why alignment and proper training are so important. Before we examine how to properly adjust your bike and riding style, we'll first talk about the parts of the bike that are important to us. The crank arm and the chain ring allow us to push the pedals in what we call the pedal stroke, transferring human energy into mechanical energy. The pedal cycle is made up of 2 phases, the power phase and the recovery phase. The power phase is when the knee is extending from the 12 to 6 o'clock position, and the recovery phase is when the pedals are returning to that 12 o'clock position. Here the quads must provide most of the force during the power phase with help from the adductor muscle group. Now that we know some of the vital parts of the bike, let's look at how we fit your bike. Some of the issues that cause knee pain are the height of the seat and its forward and back positions. A seat that is too low or too far forward can cause excessive patellofemoral loading, and the knee becomes excessively flexed, increasing the compressive force of the patella on the femur. Some other considerations are, if the saddle is too high, pain may develop behind the knee. The easiest way to measure the seat height is to have your patient sitting on the bike, drop the pedal to the 6 o'clock position, and your knee should be flexed between 25 and 30 degrees. The ball of your feet should be directly over the axle of the pedal. Also check the crank arm length, which should be 20% of your total leg length. This can be measured by measuring your height difference from standing to sitting. You should also check for leg length discrepancies, as this may affect your fit. When returning after an injury, you should condense your normal training schedule and progress only when easy rides are pain-free. Regardless of your background, you should use lower gears and a higher cadence, closer to 100 RPM, especially those from a triathlete background who tend to push higher gears and a lower cadence. Additionally, cycling at a higher cadence around 100 to 110 RPM has been shown to recruit more hamstring and gluteal muscles, which may decrease the workload of the quadriceps. To prevent further injury, spend more time riding in the saddle, and don't increase your mileage more than 10% each week. You should also perform early season stretching and strengthening exercises. You can also perform pre- and post-workout stretches. We'll talk more about those next.
While making adjustments to the bike or riding style will be extremely helpful, interventions off the bike can be used to directly address patellar tendinopathy. Pain reduction is one of the first concerns for these patients. Rest from cycling should help reduce pain, but isometrics and transverse friction massage to the patellar tendon are also ways to decrease pain. When doing transverse friction massage, using moderate pressure for 3 to 5 minutes should be adequate for pain relief. Flexibility is also an important area to address in this population. Adaptively shortened muscles can change the angle of pull on the patella, leading to maltracking and inefficiencies of patellofemoral motion. For patellar tendinopathy, stretching the quadriceps is a great way to restore normal muscle length and reduce tension on the patella. Doing something like a Thomas test stretch, biasing the rectus femoris, is a great way to target a major muscle influencing the patella. Stretching for 3 rounds of 30 seconds should help to restore normal muscle length. Eccentric exercise is the major intervention necessary to recover from a tendinopathy. While the mechanism is not well understood, eccentric loading of a tendon seems to decrease pain and normalize the collagen fibers of the tendinous unit through tendon adaptation, decreasing neurovascular ingrowth, as well as changing neurochemical and neuromotor output. Any type of eccentric exercise targeting the quads would work to address patellar tendinopathy. Some examples might be a reverse lunge off a step, or even an eccentric squat on a decline. Lastly, plyometrics might be a late phase addition to a plan of care for someone with patellar tendinopathy. Plyometrics help the tendon readjust to accepting quick forces during activity, which can further strengthen the tendon and prevent future injury. Some examples of plyometrics that target the patellar tendon would be any active squatting or lunging movement, such as jump squats or alternating split squats.